in just Hi, everyone. We'll get started in just a moment, allowing folks into the webinar. If you're joining us, this is congenital syphilis and syphilis in pregnancy. Right, we'll go ahead and get started. Hello, my name is Destiny Kelly, and I am the manager of the NNPTC National Coordination Center. And thank you for joining us today for our syphilis, congenital syphilis and syphilis in pregnancy. This training is in alignment with the 2021 STI treatment guidelines and peer-reviewed research. We recognize the CDC may be in the process of modifying the 2021 STI treatment guidelines to comply with recent executive orders. Upon receiving additional guidance from the CDC or the release of updated STI treatment guidelines, we will ensure that our training content aligns. This webinar will be recorded and posted on the Denver PTC YouTube page. We will drop this link in the chat soon. The NNPTC is made up of 8 regional prevention training centers known as the PTCs and 2 national centers. We are funded to train clinicians in the diagnosis, treatment, and prevention of STIs, as well as provide technical assistance to clinics. You may recognize some of the names of our 8 regional centers. The 2 national centers are the NNPTC Coordination Center and the National STD Curriculum. On our homepage, nnptc.org, you can get to our training, our resources, STD-CCN, as well as the National STD Curriculum. The NNPTC Coordination Center is happy to host the STD Clinical Consultation Network. It is a free online system where clinicians can submit complex STI questions, and an NNPT expert from one of our PTCs will answer in 1 to 5 days. Clinicians can receive this information through email, phone, or text. If we have time at the end, we will take a few questions. Unfortunately, we will not be able to get to all the questions. If you have a specific patient question not related to the cases presented, please visit www.stdccn.org to submit your questions, and one of our NNPTC network experts will get back to you. Now I'd like to introduce our presenters. Our presenters today are Dr. Jason Zucker. He is an adult and pediatric infectious disease physician and assistant professor of medicine in the Division of Infectious Disease at Columbia University Irving Medical Center. Dr. Zucker focuses on sexual health for the adolescent community, both clinically and in research. His main goal is increasing availability of HIV and STI testing, treatment, and prevention services. He also serves as the New York City PTC Assistant Medical Director. Our second presenter is Dr. Erica Hardy. Dr. Hardy is an associate professor of medicine and OBGYN in the Division of Obstetric Medicine and Infectious Disease at the Warren Alpert Medical School of Medicine of Brown University. She is the director of the Division of Infectious Disease at Women and Infants Hospital in Providence, Rhode Island, and is a faculty member of the Sylvie Rattel HIV STI Prevention Training Center in Massachusetts. Her interests include reproductive infectious diseases, including sexually transmitted infections and HIV in the peripartum period. And now I'll turn it over to our presenters, Dr. Zucker and Dr. Hardy. Thank you.
All right. Thank you so much all for joining us today. It's great to see so many people interested in this really important and rising topic. Just to start, we have no disclosures. The objectives for today describe the importance of interprofessional collaboration in sexual health care, describe current STI HIV screening strategies, including diagnostic algorithms, and describe current STD HIV treatment recommendations. So I always like to start by talking about the state of STIs in the United States. And if you've been on other of these webinars over the last 3 weeks, you know that this slide gets shown frequently. We're talking today specifically about syphilis. And so, we've seen a 61% increase in cases of syphilis since 2019. So we've seen a dramatic rise in syphilis cases. Along with that, we've even seen a more dramatic rise in congenital syphilis cases. In fact, in 2023, there were almost 3,900 cases of congenital syphilis, a 106% increase since 2019. And to give you a scope of this increase, when you look back about 10 years from 2012 to 2022, we went from a little over 300 cases per year to almost 4,000 cases per year, a 10-fold increase in just a decade. And so this is a problem that's growing extremely rapidly. And this problem is not limited to any one specific location. We have congenital syphilis cases occurring across the country in the north, the south, the east, and the west. And so it's something that we all need to be aware of and all need to work together to reverse. So before I dive in, I always like to highlight the fact that it really didn't have to be this way. In fact, in 1999, there was a national goal to reduce primary and secondary syphilis cases to 1,000 or fewer and increase the number of syphilis-free counties by 90% by 2005. And the words they said back in 1999 really hold true today. As we approach the end of the 20th century, the United States is faced with a unique opportunity to eliminate syphilis. Syphilis is easy to detect and cure given adequate access to and utilization of care. Nationally, it's at its lowest rate ever recorded and confined to limited geographic areas. The last time it peaked in 1990 with the highest syphilis rate in 40 years. Elimination of syphilis would have far-reaching public health implications because it would remove two devastating consequences of the disease: the increased likelihood of HIV transmission and compromised ability to have healthy babies due to spontaneous abortions, stillbirths, and multi-system disorders caused by congenital syphilis. And sadly, while we were hoping to be under 1,000 cases, we were really nowhere near that. This chart shows cases of syphilis by stage of infection from 1941 through 2023. And I placed a blue arrow over that peak I mentioned from 1990, and a green arrow over our current day. And as you can see, we're actually closer to our peak than we are to elimination. And the second chart shows the same data from 2014 to 2023. So you can better see the dramatic rise in total cases of syphilis during the most recent time period. And we know that syphilis cases are not distributed equally. Rates are higher among individuals by their sex, race, and ethnicity. In the chart on the left, you can see rates of syphilis by age and sex. As you can see in both men and women, rates are highest among those who are youngest, with a peak in females during their childbearing years. Additionally, you can see in 2003 that the rate of reported primary and secondary syphilis was higher among men, about 23.6 per 100,000, compared to women about 8 per 100,000, and we'll come back to that shortly. What you can actually see is that while rates are higher among men, the rate among men who have sex with men has actually plateaued over time, compared to that amongst women. So you can see here that the women are increasing, while men who have sex with men are increasing more slowly. And that's clear on this chart here on the right. The bright pink line is the male to female ratio in the United States. And that line is declining rapidly because although infection rates in both men and women are increasing, the infection rate in women are increasing much faster than that of men, bringing this ratio down. And as we see more cases of syphilis among females, you can see primary and secondary syphilis in the straight line, in the solid line here, and all stages of syphilis in the dotted line here. And as we see more and more cases of syphilis, we're seeing more and more cases of congenital syphilis as well. So why are congenital syphilis cases rising? What opportunities are we missing? Well, when we look back at cases of congenital syphilis, 37% of patients did not have a timely test for syphilis. 40% had inadequate treatment, even if they were tested appropriately. 12% were other reasons or missing data. And 11% did not receive any treatment at all. And these are the things we're going to talk about today, how we can do better to try to prevent cases of congenital syphilis. So why do we care about preventing congenital syphilis? Well, there are lots of reasons, but it's mainly the fact that syphilis can infect the placenta and through transplacental infection affect the baby. Transplacental transmission to the fetus occurs most frequently in the 9th to 10th week of gestation, and it can occur during any stage of disease. The fetal abnormalities that we eventually see result from a robust inflammatory response. Therefore, they're much more pronounced after 20 weeks of gestation, even if infection occurred earlier, mainly because the fetal immunologic response is poorly developed in the first half of pregnancy. This can have devastating outcomes, including congenital infection, things like miscarriage, stillbirth, preterm birth, impaired fetal growth, and neonatal mortality. In fact, it's actually recommended that any woman who delivers a stillborn infant after 20 weeks be tested for syphilis. The risk of infection is related to a few factors. The first is the stage of syphilis, with earlier stages being higher risk than later. Maternal infection later in pregnancy being higher risk. And finally, what I'll highlight today, failure to adequately test and treat maternal infection leads to increased risk of transmission. So let's talk about how we diagnose syphilis. And the diagnosis of congenital syphilis can be difficult. Maternal non-treponemal and treponemal antibodies can be transferred through the placenta to the fetus, complicating our interpretation of serologic testing. Evaluating and treating congenital syphilis is really based on 4 steps. Identification of syphilis in the mother, determining if maternal treatment was adequate, looking for the presence of clinical, lab, or radiographic evidence of syphilis in the neonate, and the comparison of maternal and non-treponemal serologic titers. And so I always like to highlight that understanding congenital syphilis really takes an adult and pediatric approach. The first 2 steps here are understanding what happened in mom. The second 2 steps here are understanding what happened in the baby. Now that you know what we're going to try to do, I'm going to introduce you to 3 patients. They're all based on real patients I saw in clinic. However, some details have been changed to protect patient privacy. The first patient is Jen. Jen's a 34-year-old bisexual female, pregnant with her first child. Her partner of 10 years is a 36-year-old bisexual man. They're in a committed open relationship and both have same-sex partners. She presents for prenatal care at about 10 weeks gestation. Next is Eve, a 29-year-old female pregnant with her first child. She told me that the baby's father really does not intend to be involved as he didn't want this pregnancy. She presents for prenatal care at about 12 weeks of gestation. Finally, meet Alex, a 24-year-old female pregnant with her first child. She's pregnant with her high school sweetheart. They've only been together. Neither of them has ever had any other sexual partners. So the first question is, who should be screened for syphilis? And hopefully you'll understand, because of the topic of today, that the recommendation is that they should all be screened for syphilis. We should be screening all pregnant women. And that fits with the CDC recommendation for screening syphilis in pregnant women. We should be screening at the first prenatal encounter, plus the 3rd trimester and at delivery if in high risk or an endemic area. And there was a recent CDC publication that highlighted the fact that most of the country is in an endemic area. And so we really should be screening at the first prenatal encounter, as well as in the 3rd trimester and at delivery. But those aren't the only times. I want to remind people that if we're screening for other sexually transmitted infections, we should always be thinking about screening for syphilis as well, especially given the increased risk and increased rates of STIs. I see way too often people who are diagnosed with chlamydia or gonorrhea where no syphilis test was sent because it wasn't the first encounter or wasn't the 3rd trimester. We really should be screening for syphilis anytime we think about screening for sexually transmitted infections, especially in pregnant patients. So we screened all of our patients. Our first patient, Jen, had a reactive RPR with a titer of 1 to 1. Our second patient, Eve, had a reactive RPR with a titer of 1 to 8. And our third patient, Alex, had a reactive RPR with a titer of 1 to 1. So with our test results back, what else do we need to do to properly evaluate our patients and their future children? So the first step is to identify syphilis in the mother, and to do that we need testing, which we've done with an RPR. It's important to know that the tests used for diagnosing syphilis are the same in both pregnant and non-pregnant women. There are 2 types of tests for syphilis. the non-treponemal quantitative test, things like the RPR and the VDRL, with the RPR being the one used in the vast majority of places throughout the United States. And then the direct or treponemal tests that are qualitative, things like the FTA antibody, TPPA, and EIA. I can easily spend an hour talking about syphilis testing, but in the interest of time, and that's not the focus of today, I'll just remind you that we do have two different algorithms. Remember that syphilis testing is most relevant for people who don't have clinical signs and symptoms of syphilis. If people have evidence of a chancre or concern for secondary syphilis, it's a clinical diagnosis and not based on lab testing. However, we want to reverse these trends. What we need to do is we need to screen often, and assess people who might have latent syphilis or not have any symptoms. The traditional algorithm, as seen here, starts with a quantitative non-treponemal test, and if positive, uses a direct treponemal test for confirmatory testing. I always like to remind people that a positive confirmatory test can be evidence of syphilis infection, but could be current infection, but it could also be prior treated infection. Meaning we really need to take good histories to understand if people have been tested or treated in the past. The second algorithm is the reverse algorithm, which starts with a direct treponemal test, either an EIA or enzyme immunoassay, or a CIA or chemiluminescence assay. Then if positive, will reflex to a quantitative non-treponemal test. And if those results differ, we'll perform a second direct treponemal test to break the tie. Well, I'm not going through the entire algorithms in depth today. I can take questions about them at the end. But what is important is that you can use these algorithms and you can interpret them to understand whether or not your patient is infected with syphilis. In addition to serologic testing, there are some other tests we can do to look for evidence of congenital syphilis. Fetal infection may be suspected if there are characteristic but non-specific findings on ultrasound, especially after that 20 weeks of gestation. Some of the non-specific findings include hepatomegaly, placentomegaly, anemia, polyhydramnios, and ascites. I do like to remind people that a normal ultrasound is not diagnostic, and a normal ultrasound does not exclude fetal infection, but it can point us in one direction or another. So we're going back to Alex. Her RPR was reactive and her RPR titer was 1:1. Her TPA was actually negative. You know, Alex was the one who was with her childhood sweetheart and said they'd never had any other partner. Her RPR was positive, but her confirmatory test was negative, making this likely a false positive. False positives are more common in pregnancy. A positive low non-treponemal screening test can be considered a transient false positive due to pregnancy if confirmatory testing is negative, the patient has not had or does not have any symptoms of syphilis, and is at low risk of infection, for example, in this case, having only her one lifetime partner. Repeating the RPR is unlikely to be helpful. They can actually have a positive RPR for up to 6 months, but they do recommend that all women with a false positive in pregnancy should have follow-up after delivery. However, for Alex, this means that her baby does not need further workup. And this does come up a lot, that just because people have a positive RPR, if we believe that it's a false positive, the baby does not need any additional workup. So in Alex's case, we did not identify syphilis in the mother. However, what if mom had syphilis? Well, in that case, the next thing you need to know is whether maternal treatment was adequate. In determining maternal treatment, if maternal treatment is adequate, we need to be able to stage syphilis successfully. So we need to know about the symptoms at the time of diagnosis, any history of prior testing, if treated, the number and timing of doses given, and the likelihood of reinfection. Was the patient's partner treated as well, or were they not with that partner again? So we'll go back to our patient Eve. Eve's labs were notable for an RPR of 1 to 8, and her TPA was positive, consistent with a syphilis infection. She was asymptomatic, and it turns out she was never tested for syphilis previously. So what stage is she and what treatment does she need? So to understand treatment, we need to successfully understand staging of syphilis. This diagram from the New York City STD Prevention Training Center and Department of Health highlights the stages of syphilis really well. It starts with the incubation period. And I always like to highlight the fact that after a recent exposure, you may not test positive and have no symptoms for up to 90 days. Meaning in pregnancy, it's really important that individuals who are contacts of partners with known or suspected syphilis should be considered for presumptive treatment, as opposed to waiting for a test and treat strategy. After incubation is primary syphilis. Primary syphilis is primarily defined by local symptoms. Traditionally, the painless chancre we think of as typical for syphilis that generally occurs at the site of inoculation. I always like to highlight the fact that because it's painless, it's easy for it to go unnoticed. So for example, people who may have it in the throat or in the vagina or in the rectum may have no idea that they had a chancre, and so it's very common to go unnoticed. They may have some associated regional or bilateral lymphadenopathy. This stage is highly infectious and usually resolves in 1 to 6 weeks. One other thing I'd like to highlight is that we are seeing more and more atypical presentations. So I talked about the single painless ulcer or chancre at the site of infection, which is our classic presentation. We are sometimes seeing atypical presentations with multiple atypical or painful lesions at the site of infection. So again, as a reminder, whenever it comes to syphilis, we need a high index of suspicion. Syphilis can look like anything, and we need to always keep an eye on differential, particularly in our pregnant patients who are at greater risk for congenital syphilis. After primary syphilis is secondary syphilis, which is really disseminated symptoms. This is what we traditionally think of as rashes on the palms and soles, but also includes other disseminated symptoms like rashes, generalized lymphadenopathy, fevers, chills, fatigue, hepatitis, and other symptoms. There's actually a wide range of symptoms that can occur in secondary syphilis. This usually occurs 4 to 8 weeks after infection, will resolve in less than 6 weeks even without treatment, and is again highly infectious. Finally, latent syphilis, which is what we really use our RPR titers for most commonly. Latent syphilis is by definition asymptomatic, so the only way to make the diagnosis is through serology. Early latent syphilis is when it's possible to document non-reactive syphilis serology within the past year, or a patient's having symptoms of early syphilis within the past year. Otherwise, the disease is considered late latent or syphilis of unknown durations. And these designations are important because they determine what is adequate treatment for syphilis. So as I said earlier, treating syphilis is really based on stage. And this is the CDC recommended treatment and alternative treatment options. For early stage syphilis, incubation, primary, secondary, and early latent, the primary treatment is benzazine penicillin, 2.4 million units, IM times 1. For late latent syphilis of unknown duration and tertiary non-neuro, it's benzazine penicillin G, 2.4 million units IM weekly for 3 weeks. For both early and late syphilis, doxycycline is an alternative, although we'll talk about that in 1 second. And then for neuroocular and otic syphilis, it's IV penicillin. As a reminder, procaine penicillin is no longer on the market. While these are the general recommendations for treatment of syphilis, in pregnancy, it gets a bit more complicated. We don't use the alternative regimens in pregnancy because doxycycline is not safe in pregnancy. And so the recommendations are that pregnant women who have a history of penicillin allergy should be desensitized and treated with penicillin. This is because non-penicillin regimens are either contraindicated in pregnancy like doxycycline, lack sufficient data for efficacy like ceftriaxone, and do not cross the placental barrier completely like azithromycin, and therefore are not recommended for pregnant women. Otherwise, treatment looks similar to that for non-pregnant patients if we're using penicillin. However, there is one additional difference. The CDC actually recommends considering additional therapy for women who have primary, secondary, or early latent syphilis with a second dose of IM penicillin 1 week after the initial dose. This is really based on PK/PD data that shows altered penicillin levels in pregnant women with limited efficacy data and no randomized controlled trials. I will say that I usually do it in my later term pregnant patients, but there isn't a lot of evidence for it at this time. One other key to treating syphilis in pregnancy is if patients need 3 doses, making sure that the duration between doses is acceptable. In non-pregnant patients, we often accept 10 to 14 days between doses, even though 7 to 9 days is preferred. That's not considered acceptable in pregnant patients. In pregnant patients, missed doses greater than 9 days are not acceptable, and they should repeat the full course of therapy if it's greater than 9 days between doses. So how do we determine if maternal treatment was adequate? Well, that's what we just reviewed. It's staging, identifying any symptoms at the time of diagnosis, and a history of prior testing. It's treating based on the staging, with the right number and timing of doses given. And then it's thinking about the chances of reinfection and making sure individuals' partners are treated as well. In the case of Eve, based on what we just reviewed, she was asymptomatic and had never been tested for syphilis previously. So we diagnosed her with latent syphilis of unknown duration, and she received penicillin G IM weekly for 3 weeks and didn't miss any doses. One additional thing that I always like to cover is how to interpret RPR titers. So in the case of Jen, her RPR was reactive, her titer was 1-to-1 and TPA was positive. Outside records were obtained. She was actually treated 1 year ago for a titer of 1-to-64 with 3 shots of penicillin G 7 days apart. So how do we know if this is adequate? Well, treatment failures if people post-treatment have ongoing clinical signs and symptoms, or have a 4-fold increase in non-treponemal testing or quantitative testing for greater than 2 weeks. For primary and secondary syphilis, failure to see a 4-fold decrease after 12 months represents failure, although it is important to note that 10 to 20% will not achieve this 4-fold decrease, especially those who start with lower titers. For latent syphilis, late latent syphilis, failure to see a 4-fold decrease after 24 months is again representative of treatment failure, but it is again much more common if the initial titer is 1-to-8. So syphilis titers are important both for understanding if patients have treatment failure, but also as evidence of reinfection. Non-treponemal antibody titers like the RPR are used to follow treatment response and look for the chances of or evidence of reinfection. Quantitative testing involves the serial dilution of specimens to determine the amount of antibody present. And they use cards like this circular card here. A 4-fold increase in the non-treponemal titer after treatment is always abnormal. A 4-fold change in titer is equivalent to a change of 2 dilutions and is considered necessary for a clinically significant difference between non-treponemal tests. So for example, if you go from 1-to-16 to 1-to-32, that's a 1 dilution change or a 2-fold increase or decrease in titers. As compared to 1-to-8 or 1-to-32 or 1-to-32 to 1-to-8, which is a 2 dilution change or 4-fold increase or decrease in titers. As a reminder, non-treponemal test titers usually decline after treatment and may become non-reactive with time. However, in many people, they do persist for a long period of time, a response referred to as the serofast reaction. So just having a positive RPR is not enough. You're really looking for a 4-fold increase if you're concerned about reinfection. So because Jen's titer had gone from 1-to-64 to 1-to-1, it had reduced by way more than 4-fold or 2 dilutions, and she was considered adequately treated. Her titers were not consistent with new infection, and she did not need any further treatment. However, Jen actually returned at 32 weeks. She was asymptomatic, but repeat screening in the 3rd trimester were notable for a reactive RPR with a titer of 1-to-16. This represented a more than 4-fold increase from her 1-to-1 previously, consistent with a new syphilis infection. It also highlights the importance of ongoing testing during pregnancy. Because we had prior testing and we knew that this was early latent syphilis, she was treated with benzazine penicillin G 2.4 million units IM times 1. So now we reviewed and hopefully understand syphilis in the mother. I also now want to talk about the neonatal side. The Red Book is very clear that no newborn infant should be discharged from the hospital without determination of the mother's serologic status for syphilis. And so we start by identifying syphilis in the mother and determining maternal treatment was adequate. And then we move on to focusing on the newborn themselves. The pathophysiology of congenital syphilis is actually quite interesting. At the onset of disease, spirochetes are free directly into circulation of the fetus. Then there's widespread dissemination into almost all organs. The clinical manifestations result from the inflammatory response to these spirochetes and can be very widespread. The first step is looking for clinical symptoms. And these are just some of the most common manifestations of clinical syphilis. Things like hepatosplenomegaly, syphilitic rhinitis or snuffles, lymphadenopathy, pneumonia, pseudoparalysis, edema, a rash, and osteochondritis. The bold ones are the ones that actually contain spirochetes and can be infectious and require contact precautions. An examination for congenital syphilis really needs to be a complete examination of the newborn because it really can affect virtually any organ. Here we have some examples of snuffles, hepatomegaly, and jaundice, as well as an X-ray of the bone abnormalities. In this case, syphilitic metastasis in an infant with diminished density and destruction of the proximal end of the right tibia, which you can see here. And here. This is the typical desquamating and maculopapular skin lesions. These punched out, pale, blistered lesions, mainly on the ear and nasal bridge, and desquamation of the feet and palms. On the right here is a figure from the New England Journal paper on congenital syphilis, really highlighting how many different organs and different manifestations of congenital syphilis can occur. So we started by looking for the presence of clinical signs, and that's what we just looked at. Now we'll look at the presence of lab signs of congenital syphilis. Things like anemia, thrombocytopenia, leukopenia, leukocytosis, CSF abnormalities with an elevated WBC and elevated protein, and a reactive CSF VDRL. Again, some of these are quite non-specific, like anemia, thrombocytopenia, and leukopenia. So again, high index of suspicion to look for congenital syphilis. Finally, there is radiographic evidence of early congenital syphilis. Things like periostitis with irregular periosteal thickening, metaphyseal serration, and demineralization and destruction of the upper medial tibia are all potential radiographic signs of early congenital syphilis. The last step in diagnosing congenital syphilis is comparing maternal and neonatal treponemal serologic titers. For neonatal serum RPR, we should do it from blood and not from cord blood. The infant titer is greater than 4-fold higher than the mother's titer is what we're looking for evidence of congenital syphilis. So we're now going to go through our congenital syphilis scenarios. And just as a reminder, our first patient was treated with penicillin IM at 32 weeks for early latent syphilis. Her baby, though, was born at 34 weeks via C-section due to fetal distress. The exam at the time of birth was normal. Our second patient was treated with penicillin IM times 3 at 12 weeks for latent syphilis. Retested at 28 weeks and the RPR had come down to 1-to-1 from 1-to-8. The baby was born at 38 weeks via normal spontaneous vaginal delivery, and the newborn exam was normal. And our last patient is the presumed false positive. She was not treated. The baby was born at 40 weeks via C-section for failure to progress, and the exam was normal. We're now going to put this all together and look at 4 different scenarios that help us decide what further evaluation and treatment is necessary for the baby. Proven or highly probable is the easiest criteria. In this case, a mother who tested positive during pregnancy, if the baby has a physical exam consistent with congenital syphilis, a serum quantitative non-treponemal titer greater than 4-fold the maternal titer, or evidence of direct detection of treponema pallidum, like from a skin lesion or snuffles, it's proven or probable. And because it's proven or probable, the workup is frequently extensive. A CSF analysis with cell count, protein, and VDRL, CBC and differential, and other tests as clinically indicated like long bone radiographs, chest radiograph, liver function test, neuroimaging, ophthalmologic exam, and auditory brain stem response. And in practice, I find that we frequently do much of this workup for patients with proven or probable congenital syphilis. In terms of treatment, the treatment is IV penicillin G, 50,000 units per kilogram, every 12 hours during the first 7 days of life, every 8 hours thereafter, to complete a total of 10 days. Because this is proven or probable treatment, the entire course should be with penicillin. And if more than 1 day of therapy is missed, the entire course should be restarted. Any other antibiotics they may receive during this time, like antigen, don't count. The 10 days starts from when penicillin was started. And I apologize, I did not remove procaine penicillin. This used to be a secondary option, but is no longer because it's no longer on the market. Our second scenario possible is a bit more complicated. As always, it starts with the mother testing positive during pregnancy. But in this case, the baby has a normal physical exam and a serum quantitative non-treponema titer less than 4-fold maternal titer, which is reassuring. But one of the following is present. Mom was not treated. Mother was inadequately treated, including with a non-penicillin G regimen. Mom has no documentation of having received treatment, and the mother received recommended treatment less than 4 weeks before delivery. In this case, we often do an evaluation with a CSF analysis, cell count protein VRL, CBC and differential, and sometimes long bone radiographs. In terms of treatment for possible, there are 2 options. One is our 10 days of IV penicillin, and the other is a single dose of benzene penicillin, 50,000 units per kilogram per dose, IM-1. So if you're listening to this and paying attention, everyone probably wonders, why would we ever choose 10 days of IV therapy if you could do 1 single dose? When do we choose 10 days versus when do we choose single dose? And the answer is you should choose 10 days of treatment if the workup is abnormal. If the workup is uninterpretable, for example, the CSF is contaminated with blood, the workup is unable to be performed maybe because the baby's not stable, or there's uncertain follow-up. Single dose treatment is when the evaluation is completely normal. So going back to our patient Jen was born at 34, Jen baby was born at 34 weeks gestation via C-section with fetal distress, required only stimulation with good APGAR scores. Baby was appropriate for gestational age. The baby's RPR was 1 to 2, and as a reminder, mom's titer was 1 to 8. And this baby received 10 days of IV penicillin therapy after a 48-hour rule out of ampicillin and gentamicin. In this case, a workup was attempted, but was unsuccessful due to a bloody LP, and that's why the baby received a full 10 days of IV therapy. The third scenario is, again, mom tested positive during pregnancy. The baby's born with a normal physical exam and a reassuring non-treponema serologic titer that's 4-fold maternal titer. And all of the following is true. Mom was treated appropriately during pregnancy. Treatment was greater than 4 weeks or 28 days before delivery. And mom has no evidence of reinfection or relapse. In that case, no evaluation is recommended. And the options for treatment are just a single dose of benzene penicillin, 50,000 units per kg per dose times 1, or no treatment with close follow-up. Again, we should repeat the baby's titers to ensure that there's no complications. And if you're unable to be confident that you're going to be able to follow the baby up, people will frequently give a single dose of penicillin. So this is what happened with Eve, whose baby was born healthy at 38 weeks gestation via normal spontaneous vaginal delivery. The baby required minimal stimulation with good APGARs. Baby's appropriate for gestational age. The RPR titer was 1 to 1. And given that mom was adequately treated for more than 4 weeks before delivery, no further workup was performed, but the baby was given a single dose of penicillin G prior to discharge. And finally, the last scenario, unlikely. In this case, the baby has a normal physical exam and serum quantitative non-treponema serologic titer less than 4-fold the maternal titer, and both of the following. Mother's treatment was adequate before pregnancy, meaning she was treated and maybe didn't have syphilis during her pregnancy. and the mother's non-treponemal serologic titer remained low and stable during pregnancy and delivery. This is actually something we get called for a lot. In this case, the mother did not have a new infection during pregnancy, and so no evaluation is recommended and no treatment is recommended as well. For neonates who do have a positive non-treponemal test, the recommendation is to repeat every 3 months. In patients not treated at birth, it should be non-reactive by 6 months, and if reactive, consider treatment. In patients treated at birth, it should be non-reactive by 12 months, and if still reactive at 12 months, consider a lumbar puncture and 10-day course of IV penicillin. For neonates with a negative non-treponemal test at birth whose mother is positive, we recommend repeating the test at 3 months just to rule out the incubation period. So that's putting it all together for our 4 early congenital syphilis scenarios. But there is one more scenario I want to talk about. And this is occasionally a patient over 1 month of age who's getting evaluated for congenital syphilis. These are generally infants and children found to have reactive serologic tests for syphilis when they're older than 1 month of age, sometimes several years old. The first and most important step is separating out congenital syphilis from the potential for later acquired syphilis, which requires a careful review of the records, showing that congenital syphilis is possible, and making sure to consider the possibility of abuse. If greater than 30 days of age, they have reactive serologic testing for syphilis, and a review of the maternal records indicates that congenital syphilis is possible, they should then get a complete evaluation. And either full 10 days of IV therapy, or if evaluation is normal, intramuscular penicillin weekly for 3 doses. Late congenital syphilis can have a lot of terrible features, facial features like frontal bossing, saddle nose, short maxilla, protuberant mandible, oropharyngeal features like hypoplastic notch widely spaced teeth, perforation of the hard palate, skeletal abnormalities like bone of the shins, and enlargement of the sternoclavicular portion of the clavicle. They can also have fissures around the mouth, gummas on the skin, cranial nerve palsies, central nerve hearing loss, and intellectual disability. But what's most important today is the reminder that late manifestations can be prevented by treatment of early infection. And so hopefully after today, everyone understands how to test and treat both mothers and their babies for congenital syphilis. And with that, I'll stop and turn it over to Dr. Hardy.
Thank you, Dr. Zucker. That was a wonderful review. And I know each of these topics within it is sort of a talk in and of itself. So thank you. As the moderator of this session, we thought it would be helpful to go through a few cases that would help with Dr. Zucker as the discussant to sort of help determine how do we think through some of these more complex cases. I wanted to start with a few of the questions in the Q&A. So continue to put questions in the Q&A. We'll get to as many of them as we can, especially if they're relevant to the case. And if not, we're planning on hoping to answer them later as well. One clarifying question, and this may be, it sounds like your institution is using the traditional algorithm, starting with the RPR and then moving to a treponemal test, and the TPA or the treponemal antibody like IgG, IgM is your confirmatory test. Is that right?
Yeah.
There's a question here about the reverse screening algorithm with which many hospitals are doing, where you have a tiebreaker test. Obviously, starting with the treponemal antibody, moving to the RPR, if they're discordant, needing a tiebreaker test. Any comments on that? Either, besides either way it's really whatever your lab is doing. Oh, there we go.
Yeah. So I was trying to pull that up, but that's exactly
Perfect.
right. So, the algorithms just have different properties to them. And so the CDC has recently come out and again said that either one is considered acceptable. And so it's just really about which one your hospital is doing. Most people don't have a choice. They're using whichever one is available at their institution. And as you mentioned, in the case of the reverse algorithm, if you have discordant results, it does go to a tiebreaker result.
Mm-hmm. And then if you're still left with the, false positive versus early infection, because that IgM, IgG is positive a little bit before the RPR comes back positive. So you may be picking up very early. And so if you're having a positive treponemal antibody, non-reactive RPR, non-reactive TPPA, and they're at risk for syphilis, like a recent sexual contact, you would want to repeat that whole testing algorithm in 2 to 4 weeks. If you have 2 positive treponemal antibodies, but that non-reactive RPR, that's where you go back to look at their history. Is this old treated syphilis, or is this untreated syphilis with a decayed RPR? So that can get a little bit confusing.
The other thing I always like to highlight in pregnancy is you sort of have less time. So, you know, in non-pregnant persons, or pregnant patients, you have more time to sort of wait and see what happens. Occasionally in pregnancy, especially if you're getting your, it's an early 3rd trimester, and you really want to make sure people are treated before the 4-week mark. Sometimes we're a little bit more aggressive with treating, just because we don't have the time to wait that you might in a non-pregnant person.
All right, well, let's go through the cases, and then hopefully we'll get to some Q&As as well. Let's pop back to, there we go. Okay, so we'll think through this one, and this highlights one of the questions on here, so we'll see which one it is. This is a 22-year-old woman at 31 weeks gestation. She's referred to you for the management of syphilis. She was diagnosed on routine screening at her first prenatal visit around 13 weeks gestation. When a treponemal antibody was positive or reactive, her RPR titer was 1 to 128. So you have these 2 positive tests. This was the reverse algorithm. She says no prior history of syphilis diagnosis or treatment. She does on questioning say about 70 days, prior to her testing, she reportedly had what she attributed to a heat rash on her hands and feet that resolved on its own. She never sought medical treatment. No other rashes or lesions. What do you think? If you saw her at the time of this diagnosis now, what would you think through? How would you think through this? How would you treat her?
Yeah, these are really challenging. So she clearly has syphilis right now and has not been treated before. The question really is this latent syphilis, or latent syphilis of unknown duration because we don't have prior testing? Or could we say that this is really early syphilis because she had this rash on her hands and feet 70 days prior? I will say that in pregnant persons, I tend to be a little more aggressive, especially if we don't have imaging of that rash or additional sort of evidence from a provider who saw it and says, I thought that looked consistent with syphilis. I tend to be more conservative, again, just because of the sort of larger downside of that. I will say that some of my other patients, particularly in our sexual health program, if they give me a good history consistent with that, I will sometimes treat them just for early syphilis.
Yeah, so it's a great approach. So at the time of her initial diagnosis, her obstetrician administered long-acting benzathine penicillin. They made the same decision you would, and she got a weekly benzathine penicillin.
Sorry, that was my fault.
For 3 weeks. Follow-up testing 4 months after treatment showed an RPR of 128, so no change here. Non-reactive HIV antibody or HIV 4th generation assay. She is completely asymptomatic. She has a normal exam, including a normal neurologic exam. She has had no sexual contact since prior to her syphilis treatment, and a fetal ultrasound is normal at this point. What are you thinking now? What stage of, how do you think through these titers not falling? What do you think about the timing of them? What would you recommend at this point?
Yeah, this is the challenge doing this in pregnancy. We talked, I mentioned earlier, sort of, in terms of failure, they're calling it latent syphilis. You actually have up to 24 months to drop fourfold. However, we always get a lot more concerned during pregnancy because we don't know what else to do. To be honest, given that you described a really normal exam, a fully normal exam, I probably would not do anything different. She'd already gotten the 3 doses and everything. I would say that had I treated her with 1 dose originally, I probably would have done 3 doses now. But now that she's already gotten 3 doses, I probably would not do anything and would expect that this is what can happen.
Yeah. Yeah, and this illustrates this a little bit. This is a CID article from 2015, and this is just showing, in her case, it often the higher the titer when they start, like with primary and secondary syphilis, you may see some falling. And so this case was a little bit more concerning. This was a case I saw over the years that it wasn't falling, but again, it's only been 4 months. And like Dr. Zucker said, you have between 6 and 12 months to have that fall. The higher they are, the more you'll see those titers fall for unknown duration, early latent, late latent. You may not see much change at all. And so the CDC guidelines has some nice pointers about when to repeat. One of the things I thought it was good to highlight is if they are diagnosed before 24 weeks gestation, titers really shouldn't be repeated before 8 weeks after treatment because they can rise and then fall again. So sort of repeating too frequently may not be helpful for you clinically. If they're diagnosed after 24 weeks and treated appropriately, you can repeat titers at delivery. And again, the majority, because of the length of time of pregnancy, are just not going to achieve that 4-fold decrease before delivery. So a 4-fold increase, sustained increase in titer for more than 2 weeks is concerning for reinfection or treatment failure. But again, unless signs or symptoms exist of primary or secondary syphilis, you can follow the titers.
We didn't mention it earlier, but again, the reinfection thing is a big one, making sure that the partner's been treated. Obviously, I'd approach it differently if the person's part was still with the same partner, they had not been treated. A lot more concerned about reinfection at that point than the other way around.
It's such a good point. And often your local Department of Health can be a good partner in reaching out to partners, especially if the patient's not comfortable doing that. And so here's a nice slide illustrating that. This is courtesy of Khalil Ghanem, who you may have heard on some of the other sessions. So what to do when RPR titers don't respond like you think they would or like you wish they would. So again, it's usually a full 12 months or a full 24 months, depending. For late syphilis, any neurologic symptoms, you want to do a good neuro exam. If they do, then offer an LP, and LP might be recommended. Has the patient been reinfected? If yes, treat. If both are negative, so you can either follow them carefully or you can give additional antibiotics. I think in this case, I ended up retreating. I think in pregnancy, we're a lot more conservative, and I'm like, oh, it's a little bit high. But again, there's been several observational studies that suggest that there's really no short or immediate term benefits to additional antibiotics. Again, what you don't want to see is a 4-fold increase after appropriate therapy. So again, you think through that the same way. If yes, neurologic symptoms, think about an LP. Could they have been reinfected? And if the titer continues to elevate, again, consider an LP. So. The treatment is fairly efficacious. So, she got the recommended treatment. You look at her timing, it was within the 7 days even. Very effective, depending on it, and even depending on the stage of therapy, the stage of syphilis at treatment in pregnancy. And this is specifically in pregnancy. And again, you want to look at their dosing. So like Dr. Zucker said, missed dose is not appropriate. So you really want to stay in that window. Even some of the pathophysiologic changes that you can see on ultrasound or in the fetus can decrease with treatment. Some of them take longer than others, and this study just illustrates that. So especially the placentomegaly, hepatomegaly, that can take a lot more time to decrease. So she asked if her baby's going to need treatment for syphilis after delivery. So how would you, looking at those scenarios, how would you manage that? How would you counsel her?
So I apologize, I forget how many weeks she was, but essentially
it was pretty early. Yeah, she finished treatment well before 30 days.
Perfect. Yeah. As long as she was greater than 4 weeks before delivery, we're calling this adequate treatment. I think I probably would still get the neonatal titer to make sure it's less than 4-fold and do a complete physical exam on the baby. But if the exam is normal, the RPR is equal to or less than 4-fold maternal titer, the baby really doesn't need any treatment.
Yep, and that's what happened in her baby did great. And so, like we've talked about, the management really hinges on so many things, and that communication. What was the treatment of the mother, the clinical and lab data from the neonate, comparing titers if you need to, and then treatment can really range based on that. So the clinical impression is really important. So this is a second case. We have a little time for that, and this would illustrate a couple more things, and then we'll start going through the Q&A. But this is a 30-year-old G2P1, initiated prenatal care at about 8 weeks. She had her first trimester routine prenatal labs performed, and again, reverse screening algorithm now. So this is treponemal antibody was reactive. And this one, you actually do have negative testing 7 months prior, and her RPR is 1 to 128. She's negative for HIV, gonorrhea, chlamydia at that time. She reported no symptoms to her OB provider, reports male sex partners only. Because she reported no symptoms, At the time, she was treated with benzathine penicillin, IM weekly times 2 doses for early latent syphilis. And I will say this case was provided and presented at the STD prevention conference. So I'd like to give thanks to Caitlin Nichols and Heather Elder, Laura Platt, Laura Gino, and Kathy Shu for this case. But so any reflections about the treatment that was chosen here? Any other information you might have wanted to clarify?
So, I mean, we talked a little bit earlier about, for early treatment in pregnant persons, it can be 1 or 2 doses. There's that sort of
Yep.
note in there that's like you can consider 2 doses. I personally tend to do it later in pregnancy than the first trimester, just because volume of distribution and other physiologic changes may increase metabolism later. But I don't think it's unreasonable because we don't have really evidence either way. So I think the treatment seems reasonable. We have prior negative testing. So we know that it's early latent or we think that it's early latent syphilis, and so we're treating for that. So that seems reasonable to me. Yeah.
And then the one thing, so, and then I talked about partnering with your Department of Health. So this had an interesting twist. The Department of Health field epidemiologist interviewed the patient as part of a case investigation. And it depends on the state, but this state, they do interview patients with an RPR over 1 to 16, all pregnant patients with a new infection, and they can really help you and be subject matter experts with your patient partner services, contact tracing help, things like that. So making sure to pair with them. And then due to our increase in infectious syphilis cases, the epidemiologists in this state were also trained to screen for ocular, otic, and neurologic symptoms. And then, are referred to a clinical team for follow-up. And so they gathered a little bit of information as they started digging in the interview and history. And the patient did describe now this erythematous pruritic rash and ocular symptoms about 3 months prior to the interview. So if, she didn't endorse that at her first visit, so, wouldn't have known that at the time, but around the time of the rash, she said, well, I was evaluated in the emergency department for some eye symptoms. I got eye drops and the symptoms resolved. They got records. She actually had uveitis. She was given eye drops and then it totally went away and she has no symptoms now. 2 partners declined partner services. If you were consulted at this point, prior uveitis, now it's totally resolved, normal neuro exam. Any thoughts?
Yeah, obviously trickier now.
Yep.
So if it was just the rash without the eye symptoms, you'd say she could have had secondary syphilis. It fits with the timeline of the last 7 months. And the 1 or 2 doses would still be adequate treatment, even for secondary syphilis. So I think that's still there. The idea about the eye symptoms being possible ocular syphilis is certainly concerning because it could be a sight-threatening complication, and you'd want to treat it adequately. She had uveitis, which is sort of classic for ocular syphilis, and so that would be concerning to me as well. Did she get a repeat opto exam?
She did, and the uveitis had gone away as well.
Did they give her steroid drops?
They did give her steroid drops. Yep, that was part of the performance.
The Predfor, yeah. So I think in that case,
they did exactly what I think you're gonna say.
Yeah. The decreased inflammation could have been from the steroids and she might still have an infection. I probably would treat her for ocular syphilis. I would say that if she didn't get steroid drops and just resolved on her own, I think it would be a little more complicated.
Yeah, absolutely. And then the pregnancy throws in the complicating piece that you just really want to make sure that you're getting high enough, levels to the fetus. And so this patient did end up getting IV penicillin. And remember, in straight ocular syphilis, wouldn't necessarily need an LP. That's been a change in the guidelines. So yeah. So thank you. Her infant was born healthy. And since we'll wrap up, just a couple more things, screening for neurosyphilis. So don't forget to, ask about this as we're evaluating patients and using your Department of Health partners in this as well. So I'll turn it over to Dr. Zucker to wrap up.
I think we can just go to I don't think we have time for more questions. So I'll turn it back over to Destiny maybe to wrap us up.
Thank you all so very much for the cases and discussing through those. Really appreciate that. This will be posted on the Denver PTC YouTube page. And if you are attending today and registered, you will get a follow-up email with that link. So thank you all so very much for joining us today.